Greetings. I'm Dr. Aldrich Chan, neuropsychologist and psychotherapist in Miami, faculty at Pepperdine University, and the founder of the Center for Neuropsychology and Consciousness. Welcome to the CNC Dialogues. My next guest is Dr. Colin Depp. He's the Director of Research Education and Training at the Clinical and Translational Research Institute at the University of California, San Diego. In addition, he is a professor and psychologist at the VA Hospital in UC San Diego. He mentors many students and clinical scientists in multiple training programs. One of his specialties is the development of technologies and strategies to assess, manage, and treat bipolar disorder. In today's discussion, we begin by defining bipolar disorder. Dr. Depp then addresses and debunks some myths about it. We subsequently talked about the evolutionary theory behind bipolar disorder and move into diagnoses often confused with it, further touching on how depressive phases may be slightly different from those with major depressive disorder, in addition to the biological theories behind this condition. We then talk about its impact on cold cognition, social cognition, and creativity. We discuss the best treatments and practices currently known before ending with some of his future projects and reflections on what he has learned from his work. If any of this is of any interest to you, feel free to skip around. Hi, Colin. How are you?
Hi, nice to see you.
Okay. So I was thinking maybe we can start off with a brief description of bipolar disorder. I mean, outside of the obvious fact that it's characterized by depressive, euthymic, and manic phases, could you tell us what are some of the other particular symptoms that might stand out that people might or should know about?
Yeah, sure. So I think with bipolar disorder, it's a mood disorder. So its closest cousin probably is depression, major depression.
Hmm.
And it is really, as you said, characterized by periods of both depressed mood for most people, and then periods of elevated mood, which could either be what we'd call hypomania or a relatively low level of increase in mood, which would include things like maybe potentially focus on goal-directed activities, engaging in things that maybe you wouldn't normally do that are involve activity, and obviously having less sleep and focusing more on day-to-day things that are more interesting, like goals, and then more manic episodes, which are really more severe, and those involve, for some people, having psychotic symptoms, hearing voices, or being engaged in things that are more dangerous, and those are often highly disruptive to people's lives.
Okay,
So,
excellent.
yeah.
Yeah, thanks for that description. Are there any myths about bipolar disorder that you've heard over and over again and you're like, that's just completely wrong?
I think one myth is, and one thing that people focus on a lot is really that the manic episodes are really what causes the greatest amount of problems in people's lives.
Hmm.
Not to say that for many people who do have manic episodes that they don't cause problems, get people in hospitalizations or into trouble, but on average, the biggest problems with the population of people with bipolar disorder have to do with depression.
Hmm.
And one of the main reasons for that is that our treatments for bipolar depression, which really characterize probably about a third of the time that people live with bipolar disorder for on average,
Hmm.
are really the ones that seem to cause the most amount of disability and problems in daily function, work, engagement in life, and so forth. And really the part of the illness that people most seem interested in, people with lived experience really want to address the most, because it's more aversive to live with depression. So
Hmm.
I think that's certainly one myth.
Okay. And are there major or subtle differences between depressive phases of someone who has bipolar disorder versus someone with major depressive disorder?
They tend to be not that different, but I think
Mhm.
one thing that people with bipolar disorder are more likely to experience is what are called vegetative symptoms, a greater amount of sleeping, lower energy, sort of more of the physical aspects of depression.
Hmm.
compared to people with major depression. But by and large, the rest of the symptoms, such as sadness, lack of interest, are pretty similar.
Hmm. Okay.
I think it's also useful to note that it's not another myth is that people either are depressed or manic, and there's nothing in between. But a lot of people experience some combination of depression and manic symptoms, and those are called mixed episodes.
Mm-hmm.
And those are really toxic because you're both depressed as well as have a lot of energy just a feeling of agitation, and that can be really aversive for a lot of people.
Yeah. Now, I want to dive back into history and kind of uh, ask you what your perspective is on evolutionary theory in relationship to bipolar disorder. So I know that Julia Sherman's, for example, suggested that bipolar disorder developed through the middle of the Pleistocene, at which time the climate was quite extreme and vacillating between winter conditions and the temperate climate. And the theory goes that Neanderthals had to adapt to these changes, spending time hibernating in caves which would relate to the depressive symptoms, and then hunting and so forth, and foraging during the temperate climate, which would relate to the more manic symptoms. What are your thoughts about this?
Yeah, and I think it's a very fascinating question, and I think very difficult to prove any
Mm-hmm.
evolutionary theories. That said, I think what evidence that would support it would be that, and I think what's nice about all those theories is that it sort of implies that there's some aspects of it that are adaptive, that are helpful. And there's a great book called American Mania that really focuses, and it was the former chair of the UCLA Department of Psychiatry wrote it. It's really suggesting that the notion that people traveled across the oceans and took the big risk of not knowing where they're landing, and then once they're in the United States, also decided to take wagons over the Continental Divide, again not knowing where they're going. So that this idea of risk taking
Mm-hmm.
is potentially a trait that gets enriched.
Mm-hmm.
And there are differences in the prevalence of bipolar disorder by nations. In the United States, New Zealand tend to have very high rates, and interestingly, they're also in these sort of remote areas, or that may have involved some set of people that had to overcome a lot and take a big risk to get there. So I think that there's some evidence for that. And I think what you're also getting at is the sort of circadian aspect of it. And so
Yeah.
this idea that having changing sleep wake cycles
Mm-hmm.
is potentially related to the onset of these kinds of illnesses throughout time. And I think that there's potentially some evidence for that. It's just really hard to show that this is
Mm-hmm.
something that accounts for it or explains it. But I think that they are pretty appealing and interesting, and there's some evidence for it.
Okay, great. Thank you for sharing your opinion on that. I always find these evolutionary theories just so
Mhm.
interesting. It's great to get your ideas. Okay, so back to some of the more concrete stuff we might say. What are some of the most misdiagnosed conditions that are mistaken for bipolar
Mhm.
or vice versa?
Yeah, I think one is in particular borderline personality disorder.
Mm,
So that this is something that also accompanies shifts in mood, and accompanies disability and functional problems, and then might look in some sense like bipolar disorder. I think that the key differentiators there are that this idea that bipolar disorder involves a relatively stable change in mood, maybe over a period of days or weeks, whereas I think in borderline personality disorder, moods shift within a day, and
mm,
that's I think a key differentiating feature. It is certainly also possible to have borderline personality disorder and bipolar disorder, and so that's I think a key thing to consider.
mm,
I think some of the other ones that often are mistaken for bipolar disorder, or where there's significant overlap, would also include major depression. So it sort of sits
mm,
in between major depression and then disorders like schizoaffective disorder, to where there are also more additional psychotic symptoms that are in the absence of mood symptoms.
mhm,
practically speaking, in a clinic setting, you know, delineating these from each other and getting people's history to try to understand when symptoms were in the presence of a mood episode or not is very difficult. And so that's where you really often need to have medical charts or family members or others, because people just often don't really remember what
Mhm.
happened during
Right.
these episodes. And so it can be really tough. So
Hmm.
I'd say a lot of bipolar disorder diagnosis is pretty probabilistic and takes a long time, which is often, why we say that around it takes 9 years for people to between when they start getting symptoms and then when they're actually formally diagnosed and on treatment
Hmm.
for a lot of people.
So, would you conceptualize bipolar disorder potentially as a developmental condition?
That's a great question. I mean, so the other option is that it would be a potentially a neurodegenerative condition, and I think there are
Mhm.
probably
Right.
arguments in some sense for both. But yeah, I think the idea is that it is highly genetically linked. If you have two parents with bipolar disorder, you have a pretty high percentage of or likelihood of having bipolar disorder yourself. So there is certainly a inherited aspect of the illness,
Hmm.
and then it tends to start around young adulthood or late teens
Hmm.
for most people. So I think there is an argument that it has definitely some developmental aspects to it.
Hmm. There was also, I think, some talk before about the crosstalk between schizophrenia and
Hmm.
bipolar disorder as potentially even being part of the same family. I think that there were some commonalities of neuroimaging findings, like
Hmm.
the increased size of the ventricles and so forth. What are your thoughts on that?
I think and I think that's where the boundaries around bipolar disorder, and what it is and what it isn't, is still pretty fuzzy. I mean, I think there are certainly studies that have done comparisons between schizophrenia and bipolar disorder.
Mm-hmm.
Let's say by and large, things like cognitive impairments, functional outcome, and so forth tend to be better in bipolar disorder than schizophrenia. So there are ways to differentiate
Mm-hmm.
those two groups. But I think there are certainly, it's not as though they're, clean boundaries, so that there are certainly some people that are kind of in the middle, right?
Right. Mm.
And so that there are plenty of people with bipolar disorder that have significant
The
cognitive
psychotic
impairments and
features.
have ventricle enlargement and so forth. So
Mm.
I think that there is also some genetic research that also indicates some overlap in that respect as well. So
Mm.
I
Okay.
think really what I think the field is maybe potentially moving towards are really looking at some of the core symptoms of it.
Mm.
Hyper hyperactivity during manic episodes and treating sort of symptom sets as more modular as opposed to kind of really focusing on the diagnosis itself.
Mm.
Something like 90% of people with bipolar disorder have another axis 1, or I guess DSM diagnosis. So
Mm-hmm.
it's also very rare to find it in isolation from other illnesses as well.
Okay. I definitely want to dive into treatments in a little bit, but I want to stick a little bit with some of the brain findings, if you can speak to that. I, One of the articles that I looked into mentioned that one of the signature findings for bipolar disorder were hyperintensities, which for the audience are areas where there are potential lesions or demyelination or axonal loss between the frontal parietal and frontal temporal areas. Um, I guess could you speak to this in more depth, or what that might reflect, or if there are others that
Yeah.
you've run into?
Right. And so these are findings that typically suggest changes to the white matter of the brain and sort of the
Hmm.
connections between various, the key centers, the frontal lobes, for example, and more kind of foundational or mammalian parts of the brain. And
Hmm.
there have been some significant repeated findings around white matter hyperintensities in those connections, and with the theory that those are potentially blocking the crosstalk between various areas of the brain that regulate things like emotion and behavior.
Mm-hmm.
Sort of your brain stop signals might be less active as a result.
Mm-hmm.
Um, it is it is again difficult to sort of find a particular specific area of the brain or a particular thing that's specifically associated with bipolar disorder, because those things have been found
Mm-hmm.
in other illnesses as well.
Right.
I think, but that said, there's definitely something there with those findings.
Mm, okay. I think modern textbooks continue to discuss the dopamine hypothesis or the advanced monoamine hypothesis or the imbalances of the glutamate and GABA systems from like postmortem studies. Um, I guess my understanding is at the core, uh, there's a potential dysregulation between or amongst the homeostatic mechanisms within the brain that may lead to these different extremes. Is
Hmm.
that still the case? Are there other theories that are standing out now that are being more looked into, or that you would elaborate on?
Yeah, I think that what you're describing is consistent with this notion of uh, circadian rhythm disturbances. So this idea that the body has a clock that keeps
Mm,
it either in phases of arousal during the day and rest at night,
mhm,
and the systems that are in place to keep those clocks working in bipolar disorder are thought to be much more easily thrown off course.
mhm,
So behavioral evidence for that would be people that take long jet lagged flights or have shifts in circadian rhythms, such as during season changes and so forth, are more susceptible to those things. And so
mhm,
I think there's also a number of animal studies that sort of try to mimic this and discover whether treatments like lithium and so forth can stabilize those, and that they do tend to seem to do that. So I
mm,
think the circadian kind of hypotheses are pretty prevalent these days. There's also uh, more imaging findings that are aimed at sort of not just how it starts, but then what the progression of the illness is, and so those look at including changes to white matter, as you said, over the course of the illness, with the general idea that the more severe episodes that you have, that they kind of produce kind of hits that lead to degeneration.
mm. Um, it was in my conversation with your friend Phil Harvey
Hmm.
that he mentioned that in schizophrenia, severe consequences if you continue to take medication, stop medication, take medication, stop medication. That could be pretty bad for your gray matter. Is there something similar to that that's happening with someone who has bipolar disorder?
I mean, I think making peace with medications is one of the fundamental challenges for people living with bipolar disorder, to the extent that identifying the ones that have the sort of lowest drawbacks and risk profiles, the ones that um, really also, I think the other piece for bipolar disorder is having to
Mm,
let go of some of the manic symptoms that people are used to, and some find reinforcing, and then whether and which ones are actually chipping away at depression, which is, as I said before, is kind of one of the more um, di- dis- distasteful aspects of the illness, the more disabling aspects of the illness, I'd say. So I think that it's sort of pretty much the norm that people have periods of time when they're on or off medications.
mm,
As far as that being related to changes in brain function, I think that I'm not super familiar with that work, except to say that the theory would be that if you're off medications, you're at greater risk for episodes, and greater in having episodes probably
mhm,
does change uh, brain function. So
mm.
I think it stands to reason that there would be a link between that as well and deterioration.
Okay, and just to I guess touch on a point you made before that I was hoping you might elaborate a bit on. Is bipolar disorder then degenerative if it's not treated?
Right, and so there's huge amount of variability. I mean, I think the what best literature that this is out there that suggests that the more manic and longer depressive episodes you have, there are cognitive impairments that accompany bipolar disorder, and there are long-term neuroimaging studies, and our best evidence does suggest that treatments to reduce the likelihood of those episodes. And so I think it stands to reason that untreated bipolar disorder does place you at risk for that.
Mm.
There are lots of people with bipolar disorder, however, that don't participate in medications,
Hmm.
and they're very difficult to study. They're just sort of not. And so I don't know if we have a really clear trial or observational study to really definitively prove that. But I think our best evidence would be, given the people that we have seen,
Hmm.
people that stay on medications tend to stay well for longer, and therefore are probably in a better position to protect their brains.
Okay, excellent. Are there any lifestyle factors or other environmental factors that contribute as predictors of risk?
Yeah, there's quite a bit out there. So there's, as I mentioned, with the circadian hypothesis, sleep is probably the biggest single early warning sign, changes in sleep that people recognize when
Mm.
they've done surveys. And so reductions of sleep or hypersomnia, sleeping too much,
Mm.
are related to, certainly related to the course of the illness. And there have been a number of studies that have really focused on trying to stabilize those circadian rhythms to try to improve the illness. So sleep is one area. I think in terms of other lifestyle factors like exercise and diet, there have been, I think, fewer studies, although those do tend to be activities that we would prescribe to people
Mm.
for the purpose of stabilizing health, because I think the medications in many respects can cause weight gain for some people, or can alter dietary patterns and so forth. Um, of note, also the timing of eating
Mm.
is also thought to be a piece of the circadian flow during the day. So it's
Right.
not just when you wake up and when you go to bed, but the time at which you eat and stop eating during the day
Mm.
are
That's
also
interesting.
pieces.
Mm. Have you looked at all into the gut microbiota literature, and is there anything there that relates to nothing?
Yeah, I haven't. There's a huge center at UCSD
Mm.
that focuses on this, but I really haven't. I haven't looked into it very much as it
Mm.
would pertain to bipolar disorder.
Okay.
I do know it's exceptionally complex, the
Right.
number of microorganisms that people are looking at in this illness. And so I
Mm.
do think that for the future, that area of science will definitely yield some really interesting insights into how
Hmm.
bipolar disorder works, as well as how the medications work.
Right. Mm. Okay. Um, Now, I think recently the GWAS studies came up with the result that there are like 64 associated genes. I'm not sure how familiar you are with this, but I know it's quite heritable. Are there any genes in particular that play a very influential role?
I mean, I think the ones that pertain to circadian rhythms, as I mentioned before, I think have been implicated. But I think as far as um, heritability studies or GWAS studies,
Hmm.
I think that the results haven't necessarily been particularly stable across cohorts,
Ah,
and
okay.
so I think they haven't necessarily. I mean, at least in my relatively uninformed view, I don't know if there are particular specific genes that are ones that people are targeting these
Hmm.
days with bipolar disorder,
Okay.
which
Let's
is, I
move.
think, a shame, because I think that the it's really striking in this illness that the really probably still the best treatment available is an element that was first studied in the early 70s or even before that. And so in terms of treatment advances for bipolar disorder, we desperately need the translational research from basic science to humans.
Well, it's a step forward, even if some of the findings seem relatively unstable, I guess.
Mhm.
But let's move into cognition. What
Mhm.
are some of the most commonly impacted cognitive functions that you might find?
Yeah, the best evidence suggests that there are cognitive impairments in bipolar disorder.
Hmm.
Around 40 to 50% of people have a deficit in a domain. And then the ones that are most affected would include sustained attention, the ability to focus on something for a long amount of time.
Yeah.
I think also memory is affected, as well as your executive functions, your ability to plan and reason.
Mm.
And so those are the areas that are most consistently associated with impairment compared to healthy
Mm.
comparators in
Mm.
bipolar disorder. And these also are associated strongly with functioning. And they
Hmm.
don't necessarily get better a little bit, but they're sort of present in the absence of mood symptoms.
Mm.
So they're not just sort of part of the mood shifts, but they do seem to
Okay.
be part of bipolar disorder.
So yeah, I was just about to ask if it changes depending on whether they are manic or whether they are depressive.
Yeah, there are effects that I think less so with depression versus feeling in a euthymic state. But there are some effects that are present. So these cognitive deficits tend to be worse in those domains. But I think the key piece or key finding is that they are present in people that are in the absence of a mood episode, which suggests that cognitive impairments are kind of part of the symptom profile in a sense of bipolar
Hmm.
disorder.
Mm. And what are some of the most common activities of daily life that they tend to have difficulties with, just more concretely?
Yeah, if you look sort of functionally wise, I think staying at work and keeping jobs,
Mm.
as well as relationships, keeping relationships is those are, I think, it's a couple of the domains of function that seem to be most impaired. Those are, I think, also some of the more challenging ones, or ones that are harder than, let's say, basic activities of daily living, which are typically not affected. But I think holding a job and maintaining a kind of a consistent approach towards employment, as well as
Hmm.
um, relationships. There's a much higher rate of divorce, for example, in bipolar disorder compared to healthy controls.
Mm. Okay. And I imagine then if relationships and work are impacted that to that extent, social cognition is probably also impacted to some extent. What types of social cognitive functions might be impacted?
Yeah, there's a number of social cognitive abilities. So there's your ability to recognize emotion in others, your ability to kind of understand the logic and reasoning of others' minds as opposed to your own. And there
Mm.
have been a number of studies that have shown impairments also in bipolar disorder compared to healthy controls, and also kind of with the same pattern as that I had just mentioned with cognitive impairments. There that's a much smaller literature, I'd say, than the one that focuses on your
Mm.
more kind of cold cognitive abilities, like your ability to remember lists and so forth. But there is some evidence that does suggest that those are also impaired.
Okay.
And I just want to highlight that this is as opposed to a disorder like schizophrenia, where there is routine cognitive impairments in um, most, if not all, most people have some significant standard deviation level impairment
Mhm.
in some cognitive domains. In bipolar disorder, it's not everybody, and so there's much more variability within the illness about who has those or not.
Hmm. It's interesting. And since we're on this sort of topic, there is this idea that bipolar disorder is associated with creativity.
Hmm.
Is that true? I don't know, can you share some studies maybe related to that or some of your insight there?
Yeah, there have been a number of studies. I mean, obviously, the some evidence of that would be the proportion of artists, musicians, writers, and so forth with bipolar disorder. And there have been some more focal studies of bipolar disorder focusing on creative traits, from a personality kind of perspective. And there does seem to be some evidence that does show that on average, people with bipolar disorder might have some of the seeds of creativity in terms of
Mm,
personality
mm,
constructs. And I think some of the really interesting work has been done by Kate Jameson, who's a professor and uh, who has really looked at works of art over years, and has shown the amount of productivity year by year, and some of the composers, for example, that have had bipolar disorder or suspected bipolar disorder really sort of follow a interesting pattern where there's these huge surges in activity.
mm.
And I think that this, I think, is meant usually associated with accompanying manic episodes, which
Yeah.
involve huge surges of goal-directed activity and being willing to stay up all night to focus on a problem.
Mm.
And so I think in some respects that there are aspects of it, kind of getting back to the evolutionary theory, that there is some adaptive aspects of the illness, at least in
Mhm.
certain fields.
Yeah, I was going to say it seems that perhaps if since this is seemingly factual that creativity is related to it, that perhaps it does serve another adaptational purpose. Are there other paradoxical findings where there is enhanced cognitive functioning as opposed to reduced?
It's a good question. I'm not necessarily aware of any off the top of my head. I would not be surprised if there were, but
Okay,
I can't off the top of my head think of any ones in particular.
okay.
Yeah.
Is IQ impacted at all?
Well, IQ, yeah, I mean, IQ, it's a bit of a dated term these days, but I think uh, it refers to um,
We could say verbal reasoning, perceptual
verbal,
reasoning,
right?
processing speed, and working memory. Or
Right. So, of those,
mm,
I think working memory, your ability to hold data in your head, is affected,
mhm,
and verbal learning is also affected. So, and usually when we think about that, we're thinking about list learning or tasks that require holding on to information, both in the short term and then long term. And those have been some of the more reliable tasks that are associated with this. IQ is I think, probably a bigger term, and so I'm just hesitant to, sort of think about on average, because I think that in bipolar disorder, the deficits tend to be more selective. For example, ability to, knowledge of the world, for example,
mm,
or some other cognitive functions are less likely to be affected in terms of
mm.
the profile. So I think that's sort of the best estimate we are now.
Okay. And now, the diagnosis, does it more commonly occur with males or females? It's,
It's about equal, right? And so that's different from major depression, to
mm,
where women are more likely to have major depression, but there's about an equal split in males and females in terms of the rates of bipolar disorder.
interesting. Are they expressed differently in any way symptomatically?
Another good. You ask good questions. I think I think as far as as a biological variable, sex differences between the two. I don't think there are differences in, let's say, the rate of bipolar 1 versus bipolar 2, although you might want to check me on that.
Mm,
But I don't know if we've explained what those differences are. But basically, bipolar 2 only are people that have never had a manic episode and would have had hypomanic episodes.
mm,
I think that the other big difference in men and women is some of the key challenges that come about during pregnancy. So most of the medications that accompany bipolar disorder tend to be bad for fetuses, and so that's often a period of time when people have to go off of medications, and
Mm,
so
yeah.
during pregnancy and then during postpartum, that's a particularly challenging time to work with people with women with bipolar disorder.
Hmm. So what do people typically do in that situation?
Yeah, and then I think this is one of the um, really challenging aspects of the illness, because I think for one, given the genetic loading that we've talked about, people also consider having a kid or not, based on the risk of their own kid having bipolar disorders.
Hmm.
And then when they do have children, I think what's often the case is that they're taken off of any of the medications that would, to either switch to safer medications or taken off medications in general.
Hmm.
I think psychiatrists often sort of during acute phases of bipolar disorder really emphasize, let's get you stable first, and then family planning and so forth later. So really would encourage people to try to get a stable regimen so they're in the best place possible, I think, to be likely to not have major mood episodes during that. And then I think during the pregnancy, having psychological therapies and
Hmm.
focusing on sleep wake cycles and so forth,
Hmm.
things that you could control outside of medications are a big focus.
Right. Excellent. I think it's a nice segue for us into treatment.
Mhm.
So, talking about psychotherapies, is there a particular type of psychotherapy that's been shown to be most effective with? I guess it might differ also, though, right? If it's bipolar 1, 2, or even cyclothymia.
Mhm. Yeah, I think really the ones that are geared towards bipolar 1 or 2 are pretty similar. Obviously, the focus on avoiding mania are different, but really there's some psychotherapies that have been tested and not to the extent of ones for depression or even for schizophrenia. So again, bipolar disorder is kind of behind the curve a little bit in terms of the amount of research, but
Mm,
there's really kind of three big clusters, four, I'd say, clusters of types of therapies. There's family focused treatment, which focuses on how the family unit communicates about bipolar disorder and
mhm,
reduces the amount of stress caused by the family or in the family to help preserve wellness. And then there's cognitive behavioral therapy, which gets at CBT as we're familiar with it, for depression, but then also for mania. There's interpersonal and social rhythms therapy, which combines kind of a depression treatment with focusing on circadian processes.
hmm,
And then there's also psychoeducation, both for the person with lived experience and then family members.
hmm.
Yeah.
Yeah, I think it's great that you pulled in the family systems. It's often when I have a client with bipolar disorder or any other severe mental illness, it's yes, they're impacted quite a bit, but the family members also play a huge role. Um, I think people don't pay enough attention to that sometimes. But the other thing I was wondering is specifically when it comes to therapies, how have cognitive remediation or restoration programs like computerized programs, that sort of
Mhm.
stuff,
Well,
help?
that's a newer field. There's been very little data. This is something I've wanted to do for a long time, and I think there have been a few smaller pilot studies to suggest that there are improvements around this, but that hasn't necessarily been a focus. But yeah, I think there's plenty of rationale for it because, especially for the subpopulation of people with bipolar disorder with cognitive impairments, they do impair functioning,
Mm,
and so I think having cognitive remediation, computerized, or computerized or otherwise, would be a would. There's no evidence to suggest it wouldn't help. Uh,
mm,
so I think that, but as far as clinical trials around its efficacy or what type of it is most effective, I think there's still very little known about that.
mm. Okay. So at this point in time, the gold standard for treatment would be psychotherapy and medications, and still more research to be done with that other side that we just talked about.
Yeah, I think absolutely right. So I think the key piece of relative to, I'd say, major depression, where often psychotherapy and medications are compared to each other. I think the notion here is that psychotherapy is augmenting medications,
Mm,
and then a big part of therapy often is around, as I said earlier, making peace with the medications in respect to the process of communicating with your provider about your interests, doing sort of a decisional balance around what the pros and cons of being on or off medications are,
mhm,
and I think identifying ways in which people can accept the notion that this is really a chronic illness. I think that's
mm,
different also from major depression, in that really for most people the assumption is that they'd be taking those medications or participating in some treatment indefinitely, and that's,
mm,
I think, really that's a big literal pill to swallow, and I think
mm.
for a lot of people to come to terms with that, I think it requires therapy.
Okay, yeah. Let's jump into some more, I think, fun speculative ground. So we've touched on some evolutionary theory and the potential idea that there are some adaptations. And one of the theories in evolutionary theory is that there's a mismatch, right, between how things were back in the days of hunter gatherers, even though there are still hunter gatherers alive today, versus our modern civilization. Um, the question I have for you is how do you think social media interacts with bipolar disorder?
Hmm. And that we're potentially seeing another mismatch. That's an interesting question.
Mm,
Um, I think uh, I think that's a really fascinating question. I think one of the things that I found on the positive side of things, that we've worked on Reddit through a group out of Canada that's done a bipolar disorders Ask Me Anything, and it's every year, and I think it's really remarkable how these technologies can help people ask questions and reach out and seek support from strangers around this illness, because I think it is quite isolating, stigmatized, and so I've been really impressed that sort of the best uses of the social media concept really do seem to have an impact on getting people to ask questions and be less alone. So
mm,
I think it's not all a bad story. I think from a clinical standpoint, I think with people with bipolar disorder that I've worked with, there's a lot. It's often a source of stress,
mm,
and following things and seeing opinions that provoke you. So I think it could be seen also for a lot of people, practically speaking, as another source of stress
mm,
that is more likely to destabilize them. I
mm,
think there's certainly a lot of people that I've worked with that have said things during maybe a manic episode to
mm.
friends, family, or others that they wish they could take back, but you can't because it's
Right.
out there. So
Hmm.
I think it does come up a lot, and so I think with any treatment, focusing on how to amplify the positive aspects of it, and really create some guardrails around some of the negative ones are really helpful.
Okay. Now, are there any unique tools that people listening to this now who might have bipolar disorder um, that they can potentially, sorry, benefit from?
Yeah, I think I would a couple of ones
Mm,
that come to mind would be, I think from a support standpoint,
mm,
there's the Depression and Bipolar Support Alliance, which provides free online support groups and lots of other
mm,
kinds of interventions. And I think there is a huge population of people that are either in treatment or out of it or not happy with it. And I think that's a really a great opportunity for online or other chat and other functions that really help people connect with others that have the illness. And I think can help people feel less stigmatized. So that's one I think I definitely highly recommend.
Mm-hmm.
I also, from a practical standpoint, really emphasize with my clients here behind me. I'm pointing at the VA hospital is really this idea of uh, having daily practices, obviously, that we've kind of talked about, but then also having kind of a little bit of harm reduction techniques.
Mm-hmm.
And so that would be, you know, you're going to make some decisions that might not be in your best interest. And so really coaching yourself in terms of waiting to make the decision. I think the classic example is the Amazon shopping cart. And so if you can just put something in the wish list and see if you still want it tomorrow, I think often people are persuaded not to act on the first thing. Similarly, asking other people to get their advice before moving on. So creating some guardrails. You can do this with credit cards or lots of things that help keep you from digging a bigger hole that you then have to kind of come out of. And I think that's one of the more frustrating aspects of the illness.
Mm-hmm. And from studying bipolar disorder, and I know you have publications on schizophrenia as well, actually, something came to mind, and that was introspective accuracy. This is a total pivot here, but I thought of it when I thought of paradoxical findings. Are the findings related to bipolar disorder, do they have improved introspective accuracy, or was that
Yeah,
not?
so what is introspective accuracy? So this is the ability to praise your own abilities
Mm,
and skills. And so I think classically when people are depressed, they often sort of see themselves as underperforming on life and tasks.
mhm,
And the opposite would be true in mania. And so we have a intervention program. I think it's currently tested in schizophrenia, but I think would be applicable. But is really helping people to kind of become more accurate in knowing how they're doing on cognitive tasks, and then aligning that with kind of functional goals. Because I think from a practical standpoint, what often happens in bipolar disorder is people get very excited about a particular life direction, maybe moving out of town or something like that. They
mm,
make an impulsive decision to do so, and that decision making process involves really some introspective accuracy in terms of thinking through how am I coming up with this conclusion,
mm,
and what are the processes that by which I'm making judgments about what I want to do for the future. So
mhm,
I think that there's and we've shown in studies that there are some impairments in this construct in bipolar disorder. So I think it is a target that can be ameliorated.
mm. Interesting. Okay. Um, what are some projects that you're working on now?
Yeah, I think one of the ones that I'm really most passionate about in bipolar disorder is this notion of suicide prevention in the population. So,
Mm,
of all psychiatric illnesses, people with bipolar disorder have the highest rate of suicide.
mm,
And this is an aspect of the illness that I think is kind of undertreated and underaddressed.
mhm,
And so I think what we're trying to do currently are working on developing novel treatments that are geared towards helping people identify skills that they could use in moments of despair, but then also trying to build reasons for living over time that are really customized to people that may have a chronic illness, chronic mental illness, and then also potentially cognitive impairment so that they're kind of more easily accessible. So what I'd really like to do would be to improve the whole process by which people kind of enter urgent care in a crisis and then get them into outpatient care and make progress towards the recovery rather than sort of cycling in and out of
mm,
urgent care or hospitals. And so that's been a key focus of ours. Um, I think we're also particularly interested in ways of improving social integration or social health in this population. It's a very often isolating illness, and so understanding what are the barriers, I think, to uh, making and lining up with friends and keeping friends in this population is also a focus of ours. So we have a bunch of different projects going on, and I think really are focused on maybe less so the sort of illness itself, but the effects of it
Mhm.
in terms of both suicide and then social health.
Right. Well, I mean, they're both extremely important. Um, Recently, actually, in my own building, there was somebody who recently commit suicide, and we believe it's probably related to mental illness. I'm not sure if it was bipolar or not, but it did make me a little more curious, if you're okay sharing, about you mentioned, like, creating a maybe preventative questions that may allow them to more fully, um, I guess, invest their uh, ideas or thinking towards reasons for living.
Mm-hmm.
Um, just qualitatively speaking, or I mean, if you have any quantitative data to that yet, what are some of these questions that have been most beneficial?
Yeah, I think I've done a number of suicide prevention studies, and
Mm,
I think the questions. I mean, I think what happens in a clinic setting is really often just questions about whether what to determine what level of risk people are. Are you having suicidal thoughts, and
mm,
how bad are they, and are you intending to do
mm,
them? More from a kind of a liability. Do you need to be hospitalized side of things? But I
mm,
think questions about which I think rarely get asked, which are why do you want to take your life,
mm,
and then really trying to orient the treatments that in a clinic setting around those whys for people. And then I think what would be some things that would make, I mean,
mm,
most of the time when we see people in a clinic setting or at the hospital, people are ambivalent. They're reaching out for some kind of help,
mm,
even if they're not sure it's going to work. And so there's some part of them that kind of has to have some hope that things could get better. And so really helping them identify what would be the kind of one thing that would make you not want to take your life. And really oftentimes they're not pie in the sky requests that could never happen.
mm,
They're often, getting back to work or getting to be able to talk to my family more often or something to
mm,
that effect, so that there are actual ways in which you can help people kind of put suicide in the rearview mirror.
mm,
I think in bipolar disorder is pretty interesting. It's a phenomenon where you're both dealing with the actual acute symptoms and manic episodes of depression, but then just the wear and tear of having, a set of hopes and dreams that you're trying to work for. And then I often use the metaphor of those sort of, pushing a rock up the hill and it kind of rolls back down and people get really
Sisyphus.
discouraged.
Right.
And so helping people identify how to stay in a progress state where they're not experiencing this illness as just sort of a hopeless endeavor. And I think that's been a key challenge. Obviously, doing so in the midst of treating the mood symptoms themselves.
Hmm. Okay. Excellent. Well, we're close to our time here, so um, I guess the last question I really have for you is more of a broad question, and we could possibly end with that. That's okay with you. And
Sure.
that is, what have you learned about the human condition overall from studying bipolar disorder
Hmm.
for such a long time?
I have learned. There's a great question, and I think I've learned both kind of how yeah, I guess resilient people can be. I think that would be one thing that stood out. I mean, I work in the VA military setting, we're working with veterans, and I do think that one of the things that has really stood out to me is just how remarkable people can turn their lives around from pretty desperate states when they don't see any hope.
Mm.
So that's really encouraged me to keep going, despite all the times that people miss appointments or decide that they don't want to participate in care. So I think just knowing that is possible is really helpful. And I think for me anyway, working with uh, bipolar disorder in particular is particularly interesting because it does really accompany some of these strengths both in terms of having lived through a pretty tumultuous life,
Mm.
and often people have pretty impressive stories about things that they've done or experienced in their lives. And so I guess it has made me sort of think about what really defines what's an illness or not, and what part of
Mm.
what really had a focused treatment on what could actually make things better versus sort of as a category of an illness,
Mhm.
treating it as if it didn't include any positives as well. So it wasn't really well articulated, but those are two things that really stood out to me. And I would just close with the other that when you do run into people that are highly resilient with bipolar disorder, I've worked with older people that are pretty surprised when they reach age 70 with bipolar disorder. All the people that they live around are experiencing these stressors that they're sort of saying, you know, that's nothing. I've been through so much more than that. And so
Interesting.
I do think understanding what the secret sauce was from those kind of people also could teach us a lot more about how we can
Hmm.
treat this illness.
So, sort of the idea that all their struggles throughout their life of ongoing bipolar disorder relativized the challenges of getting older itself. So,
Yeah.
that's interesting. Hmm. Excellent. Well, Colin, thank you so much for sharing all this information with us, and for anyone listening, um, if you have any links or anything that you'd like to share, or where people can follow your research and whatnot, I can put that under as well. But
Great.
otherwise, again, thank you so much for your time and wisdom.
It was a great pleasure, and thanks so much, and be well, everyone.